Today we discuss epistaxis or nose bleeding. To start with, we present a case. Patient KO, 3-year-old male from Quezon City with a chief complaint of nose bleeding. For the history of the present illness, 3 days prior to consult, patient was noted to have colds with no other associated symptoms. 2 days prior, patient had a cough. In the interim, symptoms of colds and cough persisted. On the day of consult, there was noted one episode of epistaxis with soaking of a third of a 6 by 6 centimeter towelette. For review of systems, patient did not have fever, weight loss, or weakness. There was noted frequent colds with clear discharge, noted itchy nose, and previous episode of nose bleeding. No noted gum bleeding, no dyspnea, hemoptysis, wheezing, no syncope, no vomiting, diarrhea, constipation, or rectal bleeding, no excessive thirst or polyuria or excessive sweating, no discharge in the genital area, no rashes, lumps, bruises, or joint swelling. Patient had unremarkable past medical history with no previous surgeries or hospital admissions, no allergies to food and drugs, no history of tuberculosis, pneumonia, seizures, gastroenteritis, or other comorbidities. Patient was noted to have no medications given. For the family history, the aunt had allergic rhinitis, the mother, sister, and aunt had atopic dermatitis, the grandmother had asthma. For immunization history, the patient was noted to have the following vaccinations. For nutritional history, the patient was breastfed exclusively until 4 months and was given mixed feeding until 6 months. Patient was formula fed from 6 months until now, with complementary feeding started at 7 months, noted to be mashed food. For the current diet, patient is fed milk, rice with soup, bite-sized soft vegetables, and biscuits. For the personal, social, and environmental history, patient is living with 5 household members, and they live in a 2-story cement house with wide and adequate space. The patient is given distilled drinking water, which the rest of the family also drinks. Garbage is collected 3 times a week. There's no pertinent history of travel, and the patient is exposed to cigarette smoke from clothes of a family member. For physical examination, for the general PE, patient was conscious, coherent, not in respiratory distress, and spoke in phrases. The patient's weight was 14 kilograms with height of 90 centimeters. The patient had stable vital signs with BP of 90/70, heart rate of 110, RR of 20, and a temperature of 37 degrees Celsius. Other physical examination findings were unremarkable. For the focus PE, for the ENT, no noted tracheal tenderness. The tympanic membranes bilaterally were intact. There were the tonsillopharyngeal area was hyperemic but with no exudates. There was noted abrasion on the left nostril with crusting of blood. For the physical examination of the neck, there was no noted cervical lymphadenopathy. So the primary impression is anterior epistaxis secondary to manipulation. To consider allergic rhinitis. Before we proceed to the management of the patient, let us discuss first clinical practice guidelines published in 2020 by the American Academy of Otolaryngology, Head and Neck Surgery. So, for the epidemiology of epistaxis, it has a bimodal age distribution, common in less than 10 years of age and those 70 to 79 years of age. 3 out of 4 children experience at least one episode of epistaxis, most often limited to the anterior nasal septum. And this can be caused or aggravated by digital trauma, crusting from nasal inflammation, or nasal foreign bodies. 5 to 10% of nosebleeds are from the posterior sides on the lateral nasal wall or nasal septum, and these are called posterior epistaxis. This is more common in older patients and are more difficult to control. Epistaxis is usually spontaneous, but some can be associated with systemic, hematologic, hepatic, genetic, or cardiovascular diseases. The vessel usually involved is um, from the Kisselbach's plexus or Little's area. You can see here the arteries with the labels. The anterior ethmoidal artery, posterior ethmoidal artery, sphenopalatine artery, greater palatine artery, and superior labial artery make up the Kisselbach's plexus, or what is called the Little's area. In A, this illustrates the vascular supply of the nasal septum, and B illustrates the vascular supply of the lateral nasal wall. The target patient for these guidelines are those aged greater than or equal to 3 years old and those with nosebleeds that are severe, persistent, or recurrent or affects quality of life. Exclusion criteria for these guidelines are those patients that are less than 3 years old, those with nasal or nasopharyngeal tumor, vascular malformations of the head and neck, those with diagnosed bleeding disorders, those with recent facial trauma or sinus and or nasal surgery. First, prompt management must be given. At the time of initial contact, the clinician should distinguish the nosebleed patient who requires prompt management from the patient who does not. The goal is to achieve resolution of the nosebleed and minimize recurrence of bleeding. Active versus non-active bleeding must also be distinguished. The immediate concern is the possible airway compromise into the oropharynx and airway or hemodynamic instability due to blood loss. Minor active bleeding without complications can be assessed in ambulatory settings. If no active bleeding, but there is a concern for recurrence, the patient must be directed to the ER or hospital. If there's no active bleeding and the prior bleeding was minor, the patient may be assessed in the ambulatory clinic or office setting. For the severity of bleeding, there is no standard definition of severe epistaxis. Bleeding duration greater than 30 minutes over a 24-hour period is considered to be something that should be addressed by a health professional. Prompt evaluation should be done for those that were previously hospitalized for nosebleeds, those with prior blood transfusion for nosebleeds, and those with greater than 3 recent episodes of nasal bleeding. Patient-related factors may have bearing for prompt evaluation. So these are patients with comorbidities such as those with hypertension, cardiopulmonary disease, anemia, bleeding disorders, and or liver or kidney disease. Prompt management must be done for those with evidence of or suspicion for a prolonged or large volume bleeding, bleeding from both sides of the nose or from the throat, and signs of hypovolemia. Signs of hypovolemia may include tachycardia, syncope, or orthostatic hypotension. It is best to be cautious as patient may self-report over or underestimate actual bleeding. So first, nasal compression must be done. So the clinician should treat active bleeding for patients in need of prompt management with firm sustained compression to the lower third of the nose, with or without assistance of patient or caregiver, and this should be done for 5 minutes or longer. This is an effective, low-cost, and easily performed non-invasive intervention. First, there should be an attempt to clear the nose of clotted blood, then apply the sustained bidigital compression to the lower third of the nose. There are no studies of duration of compression for effective nosebleed control. Here is an example of how to do the nasal compression. You can see the position, which is in the lower third of the nose. That is where we apply the pressure. For more aggressive management, there are some things that we must watch out for. So these are failure to stop bleeding, slow bleeding with compression, nosebleed judged to be life-threatening or unlikely to respond to compression alone, and those with posterior bleeding site. So these would be patients with continued bleeding out of the nose or into the posterior pharynx during compression. So we treat ongoing active bleeding with nasal packing for patients in whom bleeding precludes identification of a bleeding site despite nasal compression. Resorbable packing should be used for patients with a suspected bleeding disorder or for patients who are using anticoagulation or antiplatelet medication. So this is why The history is important. Nasal packing should be done for patients with active nosebleeds that have not resolved digital compression or when active bleeding precludes identification of bleeding site for cauterization or application of vasoconstrictors. So nasal packing may slow or stop bleeding and facilitate intranasal examination. So for cases of bleeding disorders, anticoagulation or vascular abnormalities, we use resorbable nasal packing. It's also advised to use resorbable nasal packing for those when placement and or removal of non-resorbable packing can lead to mucosal trauma and additional bleeding. For posterior site bleeding, we use non-resorbable nasal packing. So these are nasal packing options. You can see here the resorbable packing materials and non-resorbable packing materials. Nasal packing usually includes inspection of the nose with illumination and the use of nasal speculum for clearance of blood clots with suction. Placement of packing materials should also be done with forceps. Lubrication should also be done to facilitate insertion with minimal mucosal trauma. For severe nosebleeds, posterior packing must be done. Complications must also be taken note of, such as vagal nerve stimulation, apnea with concomitant hypoxia, and oversedation. Other complications would be the discomfort of the patient, nasal airflow obstruction to some extent by the packing, airway obstruction if there is malpositioning or the posterior packing is dislodged. So this is more common in posterior packing. There is also mucosal insult and injury in some cases. The use of antibiotic ointments with nasal packing is also controversial. For the duration of nasal packing, so this varies per severity and location, and also depends on the medical comorbidities of the patient, but it's usually 48 to 72 hours. The clinician should educate the patient who undergoes nasal packing about the type of packing placed, the timing and plan for removal if the nasal packing used is not resorbable, post-procedure care, and any signs and symptoms that would warrant reassessment. Risk factors should also be documented by the clinician, and this would include increased frequency or severity of bleeding for any patient with a nosebleed. This would also include personal or family history of bleeding disorders, the use of anticoagulant or antiplatelet medications, or the use of intranasal drugs. This might affect the severity or recurrence of nosebleeds, and this can also modify management. Specific risk factors associated with nose bleeding are as follows: prior nasal or sinus surgery, nasal or facial trauma, nasal cannula oxygen use, CPAP use, intranasal medication or drug use, the use of medications that impair coagulation and or platelet function, personal or family history of bleeding disorders, and chronic kidney or liver disease. The clinician should also perform anterior rhinoscopy to identify a source of bleeding after the removal of any blood clot, if present. This can allow diagnosis of additional nasal pathology such as nasal septal deviation or septal perforation with resultant changes in management strategies. This is an example of anterior rhinoscopy. So in this patient, the right side is being examined. In patients with recurrent nasal bleeding, despite prior treatment with packing or cautery or with recurrent unilateral nasal bleeding, the clinician should refer to another doctor who can perform nasal endoscopy. So recurrent bleeding after initial control is more common in patients whose bleeding are from areas other than the Kisselbach's plexus. Recurrent unilateral epistaxis may also be a sign of a nasal or nasopharyngeal mass or foreign body and should prompt evaluation with endoscopy of nose and nasopharynx. In patients where epistaxis is difficult to control or when there is concern for unrecognized pathology contributing to the epistaxis, the clinician may perform or may refer to a clinician who can perform nasal endoscopy to examine the nasal cavity and nasopharynx. Nasal endoscopy provides magnification of anterior nasal structures and a direct view of posterior nasal structures in the nasopharynx. This can aid in the localization of site of bleeding and direct treatment. Bleeding site can be localized in 87 to 93% of cases. The clinician should treat patients with an identified site of bleeding with an appropriate intervention, which may include one or more of the following: topical vasoconstrictors, nasal cautery, and or moisturizing or lubricating agents. Initial therapy may consist of topical treatments including vasoconstricting agents such as oxymetazoline, phenylephrine, and epinephrine. Epinephrine is effective but concern about CV effects from systemic absorption favors the use of oxymetazoline. The use of these vasoconstricting agents could be through intranasal spray or on a cotton pledget. So use of these agents could be with or without nasal cautery. After bleeding ceases, lubricants and moisturizing agents may help prevent additional bleeding at an identified site. Tranexamic acid may also be given orally or topically for acute nosebleeds. When nasal cautery is chosen for treatment, the clinician should anesthetize the bleeding site and restrict application of cautery only to the active or suspected sites of bleeding. Usually, local anesthetics are used for nasal cautery, and this include topical lidocaine or tetracaine. For topical application, direct aerosolized spray application is done or the application of cotton or pledget soaked with agent. Lidocaine can be injected into the nasal septum as well. For general anesthesia, this is usually for young children, uncooperative patients, or those requiring advanced cauterization techniques such as endoscopic cautery for a posterior bleeding site. For patients with persistent or recurrent bleeding, not controlled by packing or nasal cauterization, the clinician should evaluate or refer to a clinician who can evaluate if the patient is a candidate for surgical or arterial ligation or endovascular embolization. 6% of patients will require management more invasive for recurrent and or intractable epistaxis. This includes surgical arterial ligation, specifically transnasal sphenopalatine artery ligation or transnasal endoscopic sphenopalatine artery ligation or TESPAL, which has a 98% success rate. Endovascular embolization may also be done for bilateral sphenopalatine or distal internal maxillary arteries. This intervention is best suited for posterior nosebleeds. In the absence of life-threatening bleeding, first-line treatments should be initiated prior to infusion, reversal of anticoagulation or withdrawal of anticoagulation or antiplatelet medications for patients using these medications. Following this algorithm, we can determine whether the bleeding is severe or non-severe and follow the management recommended. So first, we assess if the patient has one or more of the following criteria applied to this episode of epistaxis. So, is it a posterior nosebleed? Is there hemodynamic instability due to blood loss? Is there a decrease of hemoglobin that is greater than or equal to 2 grams per deciliter? Or does the patient require 2 or more units of RBCs? Or 15 or more milliliter per kilogram in pediatric patients? If yes, then the bleeding is considered to be severe, and these are the following recommendations. If no, then the bleeding is not severe, and these are the following recommendations. Once bleeding is controlled, the clinician must discuss with the patient's primary team managing the anticoagulation treatment regarding continuing or discontinuing the anticoagulant or antiplatelet medication at the time of discharge. For patients who have a history of recurrent bilateral nosebleeds or a family history of recurrent nosebleeds, the clinician should assess or refer to a specialist who can assess the presence of nasal telangiectasias and or mucosal telangiectasias, so that hereditary hemorrhagic telangiectasia or HT can be identified if present. Nosebleeds from telangiectasias are the main symptoms in more than 90% of patients. In patients with HHT, nosebleed frequency often increases with age, leading to anemia and needing iron and blood transfusions eventually. Patients also have a reduced quality of life. The clinician managing the patient should educate their patients with nosebleeds and their caregivers about preventive measures for nosebleeds, home treatment for nosebleeds, and indications to seek additional medical care. Nose picking, trauma, infection, and use of anticoagulation and antiplatelet medications and hypertension are commonly associated with epistaxis, and this should be relayed to patients and their caregivers. Their primary strategy is to avoid digital trauma or nose picking and the use of simple nasal hygiene measures. Patients should be encouraged to restart saline and or lubrication to moisturize area and allow proper healing. The outcome of the intervention should be documented within 30 days or any healthcare worker who sees the patient after should document outcome of the intervention, especially for patients who had the nosebleed treated with non-resorbable packing, surgery, or arterial ligation or embolization. So even if another doctor sees the patient later on, the outcome of the intervention should still be documented. Post-treatment evaluation for complications related to invasive management, important for patient safety and medico-legal purposes, are the main goal to document nosebleed outcomes. Again, patients should be educated about secondary symptoms that require additional follow-up, such as persistent nasal blockage, pain, and or severe crusting. So here is just an algorithm summarizing the guidelines detailed in the earlier slides. So again, we start with the patient with the nosebleed and assessing whether this patient needs prompt management. Following what we discussed earlier, we just follow the flow chart and then management would be listed. Here's the continuation. So again, this algorithm just summarizes all of the steps discussed earlier. So that ends the presentation. Thank you for listening. Here is my primary reference for this report. Thank you once again.